Hello and welcome to the Acute Medical Teaching Series. We are your hosts, Shifona
and Harrison.
both senior house officers from Salisbury District Hospital.
This is a 12-part teaching series running over the next 3 months. You can find links to the other sessions on our YouTube channel or via Blackboard for the local Southampton students. This is our 4th session, and today we'll be looking at upper GI bleeds.
So what is an upper GI bleed? This is gastrointestinal blood loss whose origin is proximal to the ligament of Treitz at the duodenojejunal junction. It's around 4 times more common than a lower GI bleed, with a mortality of 6 to 13%. With upper GI bleeds, it is important to risk stratify patients, as it will help decide between urgent versus non-urgent endoscopy or discharge.
There are several different causes of an upper GI bleed, and they include a peptic ulcer, which is an erosion within the gastrointestinal wall, and it can also include inflammatory conditions such as esophagitis and gastritis, and it can also include varices. Varices are dilated vessels secondary to portal hypertension due to underlying conditions such as cirrhosis. Other conditions can also include malignancies, so if you have a gastric or esophageal tumour, these can also bleed. It can also be secondary to a Mallory-Weiss tear, which is where you have repeated episodes of vomiting which causes small tears within the walls of the esophagus, leading to low volume bleeding. And it can also be due to vascular malformations such as angiodysplasia, where you get abnormal connections between arteries and veins leading to bleeding.
Some risk factors or causes for peptic ulcer disease, which is the most common cause of an upper GI bleed, is alcohol abuse, NSAID use, stress, H. pylori, or increasing age.
And next we move on to the assessment of an upper GI bleed. So with upper GI bleeds, patients often present with hematemesis, often in the form of coffee ground vomit, and they also often present with melena, which is essentially black tar-like sticky smelly stools, and this is due to digested blood which has travelled through the GI system. They may also have features of hemodynamic instability, including shock, syncope or pre-syncope. Other symptoms include abdominal pain, and there will also be the presence of the risk factors that we've mentioned previously. When examining these patients, it's important to assess for blood loss and to look for any signs of shock. This includes assessing the patient's pallor, their pulse, their blood pressure, and also looking for any evidence of dehydration. We also need to look for any evidence of stigmata of liver disease, as this can help us guide onwards management. We can look for spider nevi, which are spider-like vessels found on the skin due to dilatation of the capillaries. There may also be the presence of ascites, or there also could be scleral icterus, which is yellowing of the sclera due to a rise in bilirubin. You can also look for palmar erythema, which is a red rash on the palmar surface of the hands. And finally, we can look for caput medusae, which are dilated umbilical veins.
Other things we can look for are signs of tumours, so for example, palpable masses or lymphadenopathy.
A digital rectal examination is also mandatory to rule out any external hemorrhoids and to look for any evidence of melena. Key investigations to obtain in patients with an upper GI bleed include a full blood count and coagulation studies. It is also important to send blood for cross-match and group and save in case of clinical deterioration and the need for blood products.
LFTs, or liver function tests, are a useful indicator for if liver disease is a cause of the bleed. An elevated urea is often noted in upper GI bleed due to blood, which is full of protein, being digested as it passes through the small bowel.
We're now going to talk about the GBS score. So following the assessment of the patient, a GBS score can be calculated to risk stratify patients. Generally, any score greater than 0 indicates need for medical intervention. If the score is 0, you can consider discharging the patient with an early outpatient endoscopy. If the score is 2 or more, the patient should have endoscopy as an inpatient within the next 24 hours.
So you've identified that the patient has an upper GI bleed. What next? The main goals of management are 1. To stabilise the patient, and 2. Endoscopy.
So let's have a look at stabilising the patient and resuscitation. If the patient is hemodynamically unstable, consider transfusing the patient with blood, platelets and clotting factors in line with local protocols. Generally, you want to target a HB greater than 70 in these patients. We'd also consider a platelet transfusion if the patient is actively bleeding and they have a platelet count of less than 50. We can also consider things such as FFP or fresh frozen plasma, as well as cryoprecipitate if they have deranged clotting function in form of their PTINR, their APTT, or their fibrinogen. We can also consider if they're on any anticoagulants such as warfarin or a DOAC, as these will have their own reversal agents. In the case of warfarin, we would consider IV vitamin K and prothrombin complex concentrate, otherwise known as Octaplex, and in DOACs we can consider some of the newly licensed therapies.
If you have identified the cause of the bleed to be varicose, then you can give terlipressin and prophylactic antibiotic therapy. You should consider starting the patient on IV PPI with an omeprazole load, so 80 mg IV, followed by a BD IV omeprazole of 40 mg. This will depend on which hospital you work in and the availability of endoscopy, especially over the weekends. Some hospitals do not give IV PPI prior to endoscopy for non-varicose bleeds, but in Salisbury we give to all upper GI bleeds.
Once we have stabilised the patient with medical management, we then move on to endoscopic management, and this varies across whether or not the bleed is variceal or whether it is non-variceal. In the case of a variceal bleed, we can consider band ligation, and if this fails, we can consider a TIPS procedure. In the case of non-variceal bleeds, endoscopic management often consists of clips, thermal ablation, and adrenaline.
So in terms of management, if we look at the UK Acute Upper GI Bleeding Bundle from the British Society of Gastroenterology, we get the following pathway. So as mentioned previously, once we recognise an upper GI bleed, you would perform resuscitation, risk assess the patient and provide treatment as specified. We would then refer the patient on for endoscopic management. As always, make sure to check your local guidelines for any variations in these.
Interestingly, from these guidelines, the British Society of Gastroenterology advise continuing aspirin in patients with an upper GI bleed. However, they do suggest to suspend all other antithrombotics such as warfarin, DOACs, or heparins. Thank you for attending our teaching session today. I am Harrison.
And Shifona.
Hope to see you next time.